Good morning again. Thanks for joining us and continuing with us. It's my distinct pleasure to introduce the next presentation. It's Concepts of Pain Management in HPP, and this is presented by Dr. Christopher Sobey. Dr. Sobey is an associate professor of clinical anesthesiology and pain medicine at Vanderbilt University Medical Center in Nashville, Tennessee. He serves as a fellowship director for pain medicine, and his areas of expertise include interventional pain management, neuromodulation, musculoskeletal pain, chronic low back pain, and neuropathic pain. Thank you very much for joining us this morning. We really look forward to your talk.
Thanks so much, Dr. Rush. I really appreciate it, and thanks for a fantastic talk that you gave. It's always fun to follow the keynote speaker, so I'll do my best to try to follow with some really good information for patients about pain management and hypophosphatasia. So we'll just move forward here. I do have just a couple conflicts. I have some grants from interventional neuromodulation companies that I utilize, but nothing in relation to what we're discussing today. And any off-label treatments or medications that will be clarified during the talk as off-label for use for pain management. So just moving forward to the goals and objectives of today, we're going to discuss pain pathology in hypophosphatasia, meaning where is pain actually derived from and how do we treat that. It's mostly in the bone, as would be expected based on a bone mineralization disorder, but also, as Dr. Rush mentioned, in the muscles and the central nervous system as well. We're going to review some evidence behind treatments. Unfortunately, that evidence is pretty small at this point, but we'll review what is available. And then we're going to go into a lot of general strategies for pain mitigation treatment and touch on all sorts of different options to develop a multidisciplinary regimen for managing your pain. So we'll jump right in on discussing the pathophysiology. So as Dr. Rush mentioned in his talk, and I'm sure most of everyone on this call is aware, hypophosphatasia is an inherited metabolic bone disorder, and that includes defective bone mineralization, skeletal abnormalities, premature craniosynostosis, and premature loss of baby teeth or deciduous teeth due to mutations in the tissue nonspecific alkaline phosphatase gene, and that in itself leads to diminished activity of the enzyme at target tissues. And the defective bone mineralization results in an excess of unmineralized bone matrix. So what that results is large, widespread bone mineralization issues such as osteopenia, intervertebral disc calcifications and calcifications of ligaments and muscles, as well as fractures of various kinds. You can get stress fractures with fairly benign activities, and that can usually involve long bones like the femurs, but also can involve tubular bones in the ribs. Muscle-based pain is very common in patients with hypophosphatasia, and that can be due to muscular insufficiency, but also you can get myopathy, which is typically more proximal muscles, meaning closer to your chest and abdomen area rather than out towards the edges of your extremities. And then you can also get periarticular or paraspinal ligamentous calcifications that can reduce the ability to move and flex and stretch. And then lastly, dental pain is common as well with loss of the deciduous teeth early on. Then lastly, treatment-related pain. So sometimes some of the treatments that we provide can cause pain in themselves. This can be from medications or GI issues or even injection site reactions with the recombinant ALP. And that injection site reaction usually manifests as pain, bruising, redness, irritation, or can even develop ectopic calcifications at the sites of injection. So that's always something that is discussed at those consults when it is recommended to proceed with those type of treatments. So just wanted to start with some X-ray images to help demonstrate what is often seen in patients with HPP. Here on the far left is a right elbow radiograph, and that shows a pretty well-defined calcification on this arrow here at the top, and it's around what's called the lateral epicondyle, which is the outside aspect of the elbow, and that painful calcification, which can be painful to touch, painful with movement, it seemed to be diminished pretty well with local steroid injection into the calcification over time. And that's viewed here at the lower X-ray here on the far left image. In the middle, you see bilateral stress fractures in a femur cortex, and the cortex is the outside bone of the femur, and you can see them on both right and the left side here, and that's in an adult patient with hypophosphatasia. And then lastly, on the right, you see these small subtrochanteric, meaning below the this bony prominence in the bone, and you see there's a small line here, and that would lead is diagnosed as a pseudofracture, meaning it's an incomplete fracture of the femur bone, which is your long bone. And then after a falling accident, because they had this small fracture, he actually developed a full fracture and had to get stabilized with hardware there. And a lot of times fracture management may require prolonged casting and management because it takes longer for those bones to heal in this patient population. So moving on, what kind of pain complaints are we seeing? And hypophosphatasia in itself is a pro-inflammatory state. So patients are at risk for demonstrating more widespread pain in the muscles and the joints themselves. And it's thought that elevated levels of pyrophosphate do contribute to this pro-inflammatory state where you have your body's inflammatory markers are elevated throughout. There's also been some debate whether in chronic pain states such as multiple joint arthritis actually have a strong neuropathic component, and you see that in hypophosphatasia too, because a lot of the patients have neuropathy or other more neuropathic complaints. So that can include burning type pain or temperature sensitive pain, and that is primarily due to a conversion of our periarticular, which are the neurons right around the joints themselves, to become more hyperactive. And that leads to something called peripheral sensitization, which I'm going to get into a little bit more in a subsequent slide. But this, in general, chronic pain states that are become more widespread and more sensitive have to do with both peripheral nerve and central, meaning spinal cord and brain, sensitization of other nerve aspects in your body. So there's a paper that came out very recently by international collaboration of HPP leaders in research, including one of my colleagues, Dr. Catherine DeHeer here at Vanderbilt, but it looked at the burden of illness in patients with hypophosphatasia from a survey, and basically looked at adult hypophosphatasia patients who had reported pain and disability, as well as health-related quality of life outcome studies, and that's shortened to HRQOL. And they looked at 3 different surveys: a brief pain inventory, short form, a health assessment questionnaire, disability, and then a health survey as well. These patients consisted of 304 adults. About 45% had adult onset of hypophosphatasia, meaning they were diagnosed as an adult. A third of them had pediatric onset. The other percentage was undefined as to when they were actually diagnosed. And the median age of onset was about 48 and a half years old. And then 38% of those that were surveyed demonstrated greater or equal to 5 hypophosphatasia manifestations. And what's defined as manifestations is skeletal or different body systems having problems or concerns related to hypophosphatasia. And those systems include the skeletal system, muscular, dental, neurologic, renal or kidney, metabolic, rheumatologic, respiratory or lung, and then pain symptoms. And those were the determined body systems that should or could have impact by hypophosphatasia. And then 62% of those surveyed reported at least one or greater than one fracture or pseudofracture during their lifetime thus far. Then looking at this burden of illness information, they were able to look at the brief pain inventory scales, which demonstrate an average or median pain severity of 3.5 out of a scale of 10, and pain interference score of 3.3, again out of 10, meaning that most patients did have some degree, mild to moderate degree of pain severity. Now, obviously, there's a range in there. So the range went all the way from 1.5 to greater than 5. Towards 5.5. So many of the patients did have moderate pain, demonstrating that this is something that needs to be addressed in patients treatment plans. If you look at disability on the survey, there was, out of a scale of 0 to 1, the median disability was 0.3. So most patients had some mild to moderate degree of disability as well. And the greater number of hypophosphatasia manifestations correlated, as you would expect, to significantly poor scores on all scales, meaning their pain was typically worse, their disability was typically worse, and the physical, mental component summary scores were also typically worse. Now, there was no difference in looking at patients who were diagnosed when they were children versus those who were diagnosed as an adult, except for the question on disability and the question of pain is at its worst. So patients who had the worst pain typically had diagnosis as children instead of as an adult. But it did show that there is a substantial burden of illness that is associated with reduced patient-recorded health-related quality of life scales, regardless of the age of disease onset. So we're going to move on now to review the evidence behind the treatments. So in terms of treatments, so treatment-based disease modification is usually the goal of all of treating patients with not just HPP, but also with any patient that has any chronic illness disease. We're trying to modify the main problem at hand. And so the goals are things like trying to improve patients' fracture healing and reduce the fracture frequency, trying to reduce or prevent pseudofractures, and also to improve function and reduce disability in general. And that has to do with certain medications such as recombinant ALP, which can be very effective in treating both the fracture risk as well as pain issues by modifying this disease process. And this, again, is a preferred way of treating pain because you're treating the source of the problem rather than just masking the problem with certain medications. Unfortunately, however, recombinant ALP has not consistently correlated with statistically significant reductions in pain scores. However, in many studies, it has in fact demonstrated improved pain in patients who are on that treatment. Now, when people think of bone mineralization issues, you often think of using a medication called bisphosphonates. When you have patients with osteopenia or osteoporosis, and they're more at risk for getting hip fractures or vertebral body compression fractures, bisphosphonates are typically what are thought of as the first line treatment for that. But in hypophosphatasia patients, they're contraindicated because they diminish the ALP enzyme activity. And as we've discussed, hypophosphatasia is a disorder of bone mineralization, which is unlikely to benefit from a therapy acting on this bone resorption treatment. So the literature only has a few cases that are specifically aimed at pain outcomes and treatments. And here are 3 of those case series that I was able to pull up, 2 of which are related to NSAIDs, or non-steroidal anti-inflammatory drugs, treating the systemic pain complaints as well. I'm sorry, my Siri's talking. For systemic pain complaints, as well as one for parathyroid hormone, which was shown to improve pain and fracture healing in patients and adults. The effective use of NSAIDs makes a great deal of sense, as I've discussed before, because HPP in general is a pro-inflammatory state, in that the process of abnormal bone development results in the activation of inflammatory pathways. So NSAIDs help to mitigate and reduce this your body's own natural surge in inflammation. Now, this case report looking at patients treated with parathyroid hormone for chronic painful femur fractures demonstrate improved pain, mobility, and fracture repair as well in this patient population. And the theory was that residual activity of one component of the ALPL gene mutation might be affected by using parathyroid hormone. But really, there's not been any further widespread studies looking specifically at pain in this patient population because it is so rare. So this is where I kind of want to look at the big picture of treating pain in general. And treating chronic pain disease is not specific to HPP. or any bone mineralization disorder, honestly. And because unfortunately, a lot of pain literature is inadequate because we look at subjective outcomes of pain scores, and pain complaints rather than objective markers. So when you look at diabetic treatments, you look at glucose control, you look at something called the HbA1c, which is a measurable quantity that we can trend over time, whereas pain is how the patient is feeling at that moment, or and trends over time about a subjective endpoint. So it's a lot more difficult to look at pain outcomes in that. So usually what I recommend is looking at functional outcomes, looking at disability scales, looking at personal and the patient's own personal ability to promote their own health, look and function in both their job, occupation, and their families. So that's a more objective and effective way to look at how to treat pain. So the undertreatment of pain can be really devastating for chronic pain patients, and it needs to be considered as a very important component of a disease process. So I kind of broke it down to 4 different sections of how undertreatment of pain can affect patients. So there's the physiological component, the emotional component, functional component, and socioeconomic. And these candidly do overlap to a certain degree, but we'll kind of delve into each of these. So starting with the physiological component, you have changes of the undertreatment that can exacerbate syndromes of hypersensitivity. So in general, we all have multiple different types of nerves. We have sensory nerves, we have pain nerves, we have temperature nerves, motor nerves, position sense nerves, etc. And each of these nerves is designed to only process identified signals. So when you feel heat, that's activating one specific type of nerve receptor. When you feel pain, it's a different type. When you feel pressure, it's a different type. So the problem is when you have, and this has been shown in multiple studies now, in chronic pain maladies and chronic disease processes, you start having a crossover effect where non-pain nerves start acting and activating pain nerves. So you have this increased sensitivity to non-painful stimuli or lower threshold painful stimuli. And this change in the nervous system is really what develops a lot of the chronic issues when you have undertreatment of this physiological consequence. So what we deem this are 2 things: either peripheral nerve sensitization, if you're talking about nerves that are outside of the spinal cord in the brain, or central sensitivity or central sensitization if it's involving the spinal cord and the brain. And they kind of go together, to be candid. It's hard to differentiate specifically with testing. So we lump them together when we're talking about pain maladies. But this physiological change has a major impact in how patients can improve over time. You have decreased longevity and decreased length of life when patients are managing chronic pain or undertreated chronic pain issues. It also can increase your risk of things like deep vein thrombosis, increase your things like weight gain, because you're less likely to be functional and move more. So there can be a widespread implication on a lot of different parts of your body just because of the pain limiting your ability to participate in normal activities. That moves on to an emotional component. Pain obviously is a very, very highly charged emotional state. And not just because of the discomfort that the patients are experiencing at that time. There leads to be fear in movement or anxiety regarding what you can and can't do for specific days, or planning a trip can be very anxiety provoking because you don't know how you're going to feel getting to the location and whatnot. And that leads to things like depression or guilt that you might be an outlier in the family or in your friend group because you're not able to keep up or participate. And that can often lead to negative effects like anger. So having a clear understanding of what that emotional component brings to and how to manage it is very important. Then the functional aspect, disability is defined as alteration in an individual's capacity to meet personal, social, or occupational demands because of an impairment. And obviously, this is correlates very well, but disability and pain go hand in hand. It is very common. Actually, pain is the most common reason for patients going on disability, meaning they're not able to work anymore. So undertreatment can lead to that type of concern as well. And then lastly, socioeconomic. So patients that are in chronic pain are going to be seeing providers more often. They're going to be utilizing more resources from the healthcare system, and not able to be as higher in their earnings because they're not able to more consistently be at work. So that can definitely have an impact in patients' well-being. So we're going to move on to treatment strategies. Here's a list of treatment strategies we typically regard, and I put in red those that are applicable to patients with hypophosphatasia. It can be specific in terms of interventions or injections, and if you're being told that an injection or an intervention could be helpful, I think that's not unreasonable, but it needs to be discussed with a specialist, either an orthopedic or interventional pain specialist regarding that. So let's move on to medications. I typically start with medications when we talk about treatments, just because that's mostly what patients' expectations are in terms of treatments. Now, I make it very clear in our consults that when you're seeking treatments, medications are one component of the treatment. And it should not ever be the only component. There are a lot of patients who really do not like taking medications, and that is absolutely fine. We need to tailor your treatment regimen to what you, as a patient, feel most comfortable proceeding with. And also consider that medications can have side effects as well. So I've listed here a list of 6 different categories of medications that we'll go through here. Just to start, it's important to discuss really the escalating nature of pain treatment. So when we start any pain treatment or regimen, you need to start with the most safe and least basically the least likely of having any adverse effects, because pain medication treatments can be often the side effects can be worse than the actual pain that you're incurring. So it's important to step up and use the lowest dose, the lowest number of treatments as possible. This is a depiction of the WHO or World Health Organization ladder. It's specifically in regards to when to employ opiate medications, which we'll get into in a future slide to discuss. But it's really important to understand that we need to escalate over time, and that often escalating too fast can lead to not just complications with medications, but also the sustainability of a regimen, as a lot of times tolerance can come into play when we talk about certain treatments. So we'll start with NSAIDs. NSAIDs are kind of the base recommendation for treatment of bone-related pain and muscle-related pain because of the pro-inflammatory state of these of those types of pain, and that applies obviously to hypophosphatasia. Here's a list of both over-the-counter and prescription NSAIDs that we typically discuss. Ibuprofen, naproxen are over-the-counter, as well as diclofenac in terms of the topical diclofenac, which is 1%. The others are going to be prescription-based NSAIDs, which might have a little bit more risk, a little bit more concern, and should be under the supervision of a provider. But in general, the mechanism of non-steroidal anti-inflammatories is inhibition of the cyclooxygenase enzyme, or COX enzyme, and that's an enzyme that catalyzes or starts the formation of inflammatory processes. Those inflammatory mediators are called prostaglandins. So when you block the COX enzymes, you're preventing the formation of prostaglandins. The analgesic effect, or the pain relieving effect, is usually seen, or can be seen with the first dose, but the anti-inflammatory effects can actually take several days to occur. Most COX inhibitors are non-selective, except for there's one currently on the market called celecoxib or Celebrex that is a selective COX-2, And really all that means is that you can have reduced GI effects and some slightly reduced platelet inhibition, meaning bleeding, reduced risk of bleeding effects with this, but mostly it's the GI protection that Celebrex or celecoxib provides. And that kind of goes to what the cyclooxygenase enzyme is involved with. It's involved with a lot of different processes: gastric protection, kidney function, blood clotting, and also obviously the inflammation cascade as well. And you wanted to determine which of these is most helpful based on patient risk factors and what can be tolerated. So typically NSAIDs don't cause sedation or constipation. It can cause nausea when taken without food, not with food. So typically we recommend taking NSAIDs with something in your stomach. And there's oral forms, there's topical forms, and there's IV or intramuscular forms as well. And I just listed a couple regimens that are often employed, but usually the peak concentration occurs within the first 1 to 4 hours, depending on which one you're picking. And the presence of food does delay the absorption, but it does not affect the peak concentration, meaning it might last longer in your system, but it should not take away from the peak effect. And then a lot of times when you have things like kidney dysfunction or bleeding disorders, topical NSAIDs like diclofenac gel or Voltaren gel can be utilized in place of oral forms. Now, these medications are eliminated through the liver or stool. They don't involve the kidneys when they're talking about the metabolism, but they do affect blood flow to the kidneys. So if you have kidney damage, you probably need to avoid these type of medications. And the main take home is you want to use the lowest effective dose because the higher doses can result in things like gastritis or development of ulcers or like I said, worsening kidney issues or cardiac issues. Now, antidepressants are a class of medications that has a lot of emotional load when we talk about them as part of the regimen. And this just has to do with the fact that they're classified as antidepressants. Now, pain and depression, obviously there's a lot of overlap because chronic pain disorders can make people depressed. That being said, when myself or many pain providers or not just pain providers, but primary care providers or other treatment providers are talking about utilizing antidepressants to treat pain, it's because they have a direct effect on pain scores and pain severity. Now that's broken. I'm going to break these down a little bit here. There's 3 different classes of generic classes of antidepressants. We have the tricyclic antidepressants, the SNRIs or serotonin norepinephrine reuptake inhibitors, and the SSRIs or selective serotonin reuptake inhibitors. The first 2, the TCAs and SNRIs, like I said, have a direct effect on reduced pain, both in the muscular pain, can be bone pain, and can be neuropathic pain or neuropathy-based pain. The SSRIs do not have that direct effect, and those are the most commonly implemented medications for depression. People on things like fluoxetine, sertraline, or paroxetine, they might report that their pain is not as severe, but that is usually because of reduced depression, which can often improve pain scales, but it does not in itself directly affect. Now, with patients with hypophosphatasia, we've seen anecdotally in our clinic that utilizing medications like SNRIs can be very effective in improving the muscular pain complaints and the bone pain complaints. Now, the thing to understand is it's not a complete elimination of pain. It's a modulation and reduction. The analogy I usually like to use is we're trying to turn down the volume of that pain. We're trying to make it so it's not as severe and debilitating and more tolerable, but it does not typically reduce it to 0. And that's something that takes some time and understanding to really wrap your mind around. But each of these has their own place. There are some side effects related to certain medications, like tricyclic antidepressants should be really, I guess I would say, used selectively in the elderly population or patients who might have cardiac issues. But these are discussions with your physician. I'm happy to try to fill in some of these, but in the scope of this practice, I think, or this discussion, I would just like to say there are decent options for muscular and bone-based pain with this condition. So anticonvulsants, or neuromodulators, as I like to call them, can be utilized and are utilized very frequently for neuropathy-based pain, which also can be present in patients with HPP. So the ones you might have heard of before are gabapentin and pregabalin, also known as Lyrica. They were originally designed as anticonvulsants. They're not really used for seizure treatment very frequently, although they are on occasion, but they are used very frequently for nerve-based pain, reducing that burning sensation or tightening sensation that you have with neuropathy, cramping sensations, etc. And then pregabalin is also on label for muscular-based pain as well. There's other anti-neuropathic medications that are sodium and calcium channel blockers, like carbamazepine, oxcarbazepine, and topiramate. Those are usually more selective for patients that have chronic migraines or headaches, or specific neuritises like trigeminal neuralgia is very common that we utilize those. So if you have those, then you might be recommended to put on these medications. I would say that the sodium calcium channel blocking agents do have monitoring that needs to happen. So periodic labs need to be taken. So if you are receiving these medications, just ensure that the provider is comfortable doing the monitoring to keep you safe. There's some adjunctive medications like clonidine, which is a central alpha-2 agonist that can help with central-based pain and reducing anxiety as well. Certain muscle relaxants, there's multiple classes of muscle relaxants that act in various mechanisms, both in the spinal column and as well as the periphery, in the nerves in the periphery, that can help with muscle-based pain. And then lastly, talking about CBD or medical marijuana, I've received a lot of questions about this, not just in my own pain practice, but a lot of times in the talks that I have with patients with hypophosphatasia, because they've been discussing it with either on forums or blogs or with providers as an option. And now that it's becoming more and more widespread in terms of legalization, either for medical use or now even with recreational use, we get a lot of questions about these medications. So just to first clarify, I operate in the state of Tennessee. Tennessee does not have legal ability to utilize THC or medical marijuana or recreational marijuana. So in what I'm providing right now is an overview of the literature and the indications for use, and not necessarily advocating its use in states that have continue to have restrictions. But there are 133 chemicals that have been found so far in natural growing cannabis. And of these derivatives, none is more recognizable than THC, which is the most potent psychomimetic effects, meaning it affects your perception of what's going on, of all the derivatives from the cannabis plant. And other compounds are things like cannabidiol or CBD, or cannabidiol or CBN. And I'm going to give you some of the most up-to-date literature on cannabis use that we have. Unfortunately, none of this is in patients with hypophosphatasia because, again, the literature is lacking, not just in hypophosphatasia, but also in cannabis-based, because it is still determined to be a Schedule I medication by the DEA, and that really restricts the ability for us to do trials on this. So we're going to move on to THC. So the most noted compound derived from cannabis is THC. It's also the most intoxicating substance from the plant and is primarily responsible for the psychotropic effects. Ingestion of THC, whether it be orally or inhaled, causes the greatest downregulation of the body's own endogenous cannabinoid receptors, so it has the biggest effect on your body's receptors. But it also is thought to have antioxidant properties that are neuroprotective, and that results from excitation of a neurotransmitter called glutamate. Cannabidiol is CBD, and that's an agent that's been gaining a lot of popularity because it's less intoxicating than THC. It actually should not be intoxicating at all. It counter affects the intoxicating effect of THC. And based on the proportion of what type of cannabis you're using, if you have a high CBD to low THC ratio, that psychomimetic effect that I talked about can be pretty clearly modulated. It's believed to have more properties of anti-inflammatory properties or anti-epileptic properties, and can be utilized as a potential maintenance medication for those with histories of drug abuse, or seizures, honestly. And it also acts as an indirect antagonist on the cannabinoid receptors, and it is less restricted. It is actually legal in almost all states because it's derived from hemp, not from the cannabis plant. So the first systematic review that I want to discuss is published back in 2015 in JAMA, which is one of the major medical journals that we have, and it outlined the various medical benefits as well as the adverse effects associated with cannabinoids, and it compared only randomized controlled trials comparing the use of cannabinoids against placebo, or currently at the time acceptable standards of care for conditions, and that was things like pain, nausea, and various other conditions that they looked at. And the majority of trials demonstrated improvement in pain with the administration of cannabinoids, but more than half of those studies were considered to have a high rate of study bias. 17 out of 28 were deemed to have a high rate of study bias. So to take all the results with a grain of salt when you hear that kind of effect or statement. The review showed that a greater number of patients who reported greater than 30% of pain reduction used cannabinoids versus placebo, and that the trial that included inhaled THC showed the greatest reduction in pain scores compared to oral administration, with comparing to 7 trials that were conducted using what's called nabiximols, or an aerosolized spray that mixes a predefined concentration of THC and CBD. Unfortunately, though, there was no evidence of a difference in quality of life metrics when you looked at patients using cannabis-based treatments versus placebo, and there wasn't any difference in statistically significant difference in pain scores when you looked at the actual etiology of pain, such as neuropathic versus cancer, etc. So there was a trend in pain reduction, but not as statistically significant as would be hoped. The same review looked at outcomes for spasticity, and so obviously spastic muscles can be very painful and debilitating. And I wanted to highlight that because that can be present in patients with HPP because of the muscular pain complaints. 14 of the studies that were reviewed looked at cannabinoids and their effect on spasticity. Most of these were for patients with multiple sclerosis, but three had spinal cord injuries, but the results suggested that there was improved spasticity control with cannabinoid use as well in terms of a trend, but there was not a statistical significance effect. And then lastly, there was a Cochrane review, which is a pretty all-inclusive, highly conducted, high standard review that was published back in 2018 that looked at randomized control studies about the use of cannabis in patients with chronic neuropathic pain. And the data reviewed came from, again, lots of double-blinded, very high quality or moderate to high quality studies that included 16 different studies with almost 1,800 patients. Then the primary outcomes they looked at were pain reduction of greater than 50% and incidence of serious effects, as well as why patients withdraw from the studies, whether it be tolerability or other issues. So the overall conclusion of the review provided moderate quality evidence of improvement in patients' pain with the use of cannabis, with the goal of getting to 50%. And the reason why that is important is about 39% of patients reached that greater than 50% reduction versus almost about 30%. So it wasn't a huge difference from placebo. But what I can say from someone that deals with or manages patients with chronic pain on the regular is that in terms of an outcome, greater than 50% reduction is actually a really high bar to be set for a treatment. Just because there's so many things that go involved with the onset and maintenance of a chronic pain state, that getting pain to go away completely or even to be reduced consistently below 50% takes a lot of different treatments. And what they were looking at was only one treatment. So it was concluded that overall cannabinoid therapy was superior to placebo, but from pooled data in the treatment of pain, but they recommended having larger scales or randomized controlled studies, obviously, because we need to look at it a little bit more specifically about the goals of these treatments. And then CBD, obviously, it's a lot more accessible in almost all states. Like I said, a lot of patients that we have anecdotally will say that it is helpful, and then there are patients that try this that say that is not helpful for their pain. It's usually recommended more for patients with neuropathic type pain, but also has been shown to be helpful in patients with cancer-based pain and whatnot. And the thing to know that is if you are on another scheduled medication, the CBD concentration needs to have less than 0.3% THC in order for something like a drug screen to not come back as a positive for marijuana. So that is a more legal thing to talk about. And then, so in conclusion, cannabinoids have some weak to moderate evidence that they support the use in chronic pain states, but we just need to have more studies, and legalizing medical marijuana for chronic pain states and research is going to be really important in trying to develop more information about this. So I want to talk about opiates because it's a very hot topic and hot button subject that we get into both in my clinic and then in our discussions at our society meetings. I think a lot of us know why it's become a hot button subject, but before the current pandemic, we were knee deep in the opiate epidemic in the United States, and reducing the amount of adverse events from opiates is really important. So what is an opiate? It's any medication that binds to an opiate receptor, and despite the reduction in the prevalence of its use, it is still the most commonly used treatment for patients with moderate to severe pain. But there is significant risk associated with the long-term and often short-term use. And what we need to look at is what the indication is and what is the goals of treatment. So what we unfortunately do have to rely on this with patients with chronic bone or arthritic pain when all other treatment options have been exhausted, but it's always under the direct supervision of a well-qualified provider who can mitigate a lot of the risks associated with these medications. So your body has endogenous opiate receptors. So you have these receptors throughout your body. You have actually peptides called endorphins that are released that stimulate these receptors, both enkephalins and dynorphins. And these are typically released at times of stress. So if you have a trauma or fall, you get the release of these, but also can be things like high intensity workout, and that term runner's high that you hear about, that's actually because your body is releasing endorphins and acting on the brain and reducing the intensity of pain. So the most common receptor associated with pain is the mu receptor. It is found in both the peripheral nervous system, the central nervous system, as well as throughout your body, I think places like the colon. So when you stimulate that receptor, that can result in opioid-induced constipation, which is one of the main side effects of opiate use. The mu1 receptor is the primary receptor responsible for pain relief, and then mu2 is the primary receptor that is responsible for the most feared complication or side effect of opiates, which is respiratory depression, as well as things like dependence and sedation. So obviously, when we look at the effects of opiates, analgesia is the primary effect we're looking at. And why? The question is, why do opiates work for pain relief? And it has two basic mechanisms. The first one is that you have a blunting of what's called the sensory discriminative aspects of pain, meaning that if you have say you have an incision on your hand, if you take or receive an opiate treatment for that localized focal sharp pain becomes a lot more dull, a lot less intense, and there's less localization. You don't necessarily feel it right along where that incision is. Then you have a secondary mechanism, which is the reactive affective component, meaning your brain doesn't really care as much. That unpleasantness of the pain is modulated. So that's how it reduces pain scores specifically. But it has other effects on the nervous system as well. There's an initial reduction in anxiety that is independent of pain reduction. It also will very quickly or initially reduce depression scales, but when used even more than 5 to 7 days can actually result in worsening of major depression scales, and that can be a chronic issue with use. Nausea and vomiting is one of the side effects that we discuss, and that is because you have stimulation of what's called the chemoreceptive trigger zone, which is in your brainstem, and that is typically worse when patients are walking rather than lying in bed and recovering from a procedure or whatnot. But that can require taking anti-nausea medications. And then lastly, like I talked about, the most concerning effect of opiates is respiratory depression. And you have this action on the brainstem where it reduces your body's normal drive to take big, deep breaths and increase your oxygen demand. So this is typically what causes deaths in opiates or from overdose, or either unintentional or intentional. This can be reversed with antagonists such as naloxone or Narcan, and because this is such a feared consequence, it's becoming more and more common that providers are prescribing Narcan or naloxone in combination with chronic opiates, just as a safety mechanism if this does happen. And it doesn't necessarily mean you took too much of the medication. It can mean that you have a urinary tract infection and it's altering your metabolism of the medication, or you're dehydrated and don't have the same space in your body where the medication is being stored, and it becomes more potent. So it is very infrequently intentional that these overdoses occur by taking more medications. It's usually because there's something going on in the body that causes this to happen. Now, there are some hormonal effects with opiates as well. So you have decreased corticotropin releasing hormone and gonadotropin releasing hormone, which are your metabolic hormones that improve the building of muscle, the restoration of what's called homeostasis. So they basically build up your body and make it more powerful and functional. Now, the other thing is it can have an effect on your sex hormone levels, like androgen levels. So it's not uncommon that men on chronic opiates have really low levels of testosterone and need supplementation. Then lastly, there's some terms that are important. So opiates in general are known to cause tolerance, and tolerance means that you have your body is not responding to a drug and a higher dose is required to get the same effect. Now, just because you become tolerant to a medication does not mean you're addicted to the medication. Those are separate definitions. But tolerance is an expected consequence of prolonged use of opiates. And it often is something that I specifically talk to patients about. This is why the sustainability of this treatment, it comes into question, because you can't just keep escalating over and over and over without increasing risk of using the medication. And then dependence is defined as if you have a withdrawal symptom. So it's not specific to opiates, but if you have withdrawal from opiate, you can have symptoms like yawning, diarrhea, goose skin, sweating, abdominal pain, cramping, etc. And that's specific to opiates. But if you're on something like baclofen or a benzodiazepine like Ativan, you can also have withdrawal symptoms from that. So dependence is a term that's utilized with that. Again, it's expected to happen if you're utilizing these medications chronically, but the goal is to try to utilize them as little as possible. So that brings into the epidemic in itself. And before COVID, this was the thing that everyone was talking about. And now in COVID, we're actually realizing that a lot of the gains that we had made in reducing the burden of health and risk from the opiate epidemic have unfortunately been lost over the last year. It's actually, we just got some data back in Tennessee, and it almost, the 2 years of progress that we had made was almost wiped out completely in COVID. So it's kind of depressing in that sense, but it just means we have to work harder to get back to that goal. So you can see that opiate-related overdose deaths and use of synthetic opiate-related overdose deaths, that's things like fentanyl, has increased over the last decade. And a lot of the people that were started on opiates back in the 90s and 2000s were done so under the expectation that these negative effects weren't going to happen. That was guided by both prescribers and by pharmaceutical companies. But the fact is that we have a public health emergency that we need to address, and it involves education of patients and providers of what is a reasonable expectation for treatment of pain, what is a reasonable expectation for opiate utilization as a part of the regimen, and what kind of monitoring should be occurring when patients are on these type of treatments. So I'm going to go into a little bit about just general strategies for regarding movement and meditation. I think this is actually something that we can all implement to certain various degrees for pain states, whether it be bone-related pain, inflammatory-related pain, or otherwise. But I think movement is really underappreciated by patients more than by providers as an essential quality for maintaining function, which again is a better outcome study than pain scores when you're talking about chronic pain states. So the role of things like physical therapy or physical activity in general centers around assisting patients in making appropriate choices, overcoming counterproductive beliefs, and modifying dysfunctional behaviors or through their activities. So proper stretching and strengthening exercises, stabilization programs, posture corrections, and sometimes things like manual therapies like massage or chiropractic care or other manipulations can all have a place in improving patients' outcomes with their movements. I'm a big fan in my personal exercise activities of yoga, and there's actually a huge amount of literature in yoga in chronic pain states and musculoskeletal pain states, and it can be a very intimidating thing to hear when you're a patient, because most people think of yoga, they think of poses like this, which you can't expect to walk into a yoga studio and start doing that day one. But there is a wide variety of how to do yoga. This is depictions of relaxation-based yoga, which is more akin to meditation. There is chair-based yoga, so you can do yoga sitting in a chair. You don't have to be necessarily curled up in a ball, but there's a wide variety, and there are the websites that I provided earlier, or there are many online that have a wider range that can be implemented. And I really would urge individuals to consider what their physical activity goals are on a daily or weekly basis to try to make sure you are doing something. There's a key focus on cognitive treatments, and that's retraining the mind to really consider what is the severity of pain, how are we making pain either better or worse because of how we're considering it. And there's been a lot of work in cognitive therapy, behavioral therapy, or things like mindfulness training that have been very helpful in utilizing things like relaxation, biofeedback, hypnosis, pacing, distraction techniques, etc., to try to reduce the impact of moderate to severe pain and to make it so it's just a component of one's livelihood and not the defining component. And attitude is everything, and there's a lot. We talk about catastrophizing, and what that really is. I'm not a huge fan of the word, honestly, because it seems to have a negative connotation, but what it really means is it's an irrational thought process that patients have in believing something is far worse than it actually is. It doesn't have to necessarily be about pain, but in general. So it can involve making a catastrophe out of the current situation and imagining that catastrophe will lead to dysfunction in the future. Now that goes hand in hand with something called fear avoidance, which is a psychiatric model that describes how individuals develop chronic musculoskeletal pain because they avoid moving and actions. So if you have a pain, you have a painful experience, you have a decision to make, whether it's fear of pain or no fear, and whether you go through an encounter and confront that pain, you can actually lead to recovery, whereas fear of the pain can lead to avoidance activity, disuse, disability, and then depression. And then there's data supporting a lot of these treatments and modalities for pain. It's often regarded as fringe, but I think that we need to really consider them as essential in how we can, without the side effects and risks of medication interventions actually make an impact that the patient is empowered to do. And then lastly, we talked, Dr. Rush mentioned sleep, sleep disturbances with pain. It's very, very common that pain and sleep disturbances go hand in hand. So and that can be difficulty in falling asleep or having a lot of interruptions in sleep. And if you have a bad night of sleep, it can impact your pain in the morning, and the pain in the morning can impact your bad sleep. So just try to have a routine, try to get up at the same time, regardless of how much sleep you had the night before, try to go to bed at the same time, try to avoid electronics, caffeine, try not to do your exercise routine right before you go to sleep. Things that hype you up, probably not great to do in the right before you go to sleep. So I just want to, in the big picture, the treatment of chronic pain syndromes can be very difficult and frustrating, but the purpose of pain in general is to highlight a problem that you have. However, when it becomes a chronic issue, it can actually create more problems than solutions. So that's a maladaptive process. So try to form your life around and consider treatments that are relaxing and less focused on pain being the primary driver of one's day, and rather it being a modifiable component of the day. And with that, I'm done. I'm happy to take questions from y'all moving forward.
Sure. Thank you so much, Dr. Sobey. That was awesome. So much great information. And I know that a lot of people will be watching this on demand afterward to go back and look at some of the different treatment options and look at some of the data you provided, because it was really excellent. Due to time constraints, we're not going to be able to go through all the questions, but Dr. Sobey, I told everybody we could work with you to create a Q&A with some of those answers offline. So we will be able to answer all those questions at some point. But there are a couple questions that are boiling to the top.
Sure.
One, I'm going to kind of combine a few. There's a couple people who either can't take NSAIDs because they're allergic to other medications. How much NSAIDs are too much? You know, we know it reduces inflammation, but doesn't it also potentially inhibit bone growth? And just people who are asking about other options. Avoid NSAIDs because some of the risks are the same as the complications of HPP, kidney burden, bone, and if somebody doesn't have any kidney issues, should they be avoiding NSAIDs? What's your overall advice for HPP and NSAIDs?
Sure. And a lot of those questions, because they're going to be very patient specific, are things that you really need to discuss with your provider in the context of knowing your history, your labs, your risks, family history, et cetera. So but in generically, that is a huge concern that we have, patients on chronic NSAIDs that might have more risk on them than other options. And that's why we usually recommend utilizing NSAIDs for short periods of times or short bursts if they're part of the component, and not necessarily every single day for months and months and months. And so if utilizing using during flares or worsening times of activities, or when you're going to have a stressful experience. So let's say you're going on vacation and you're going to be doing a lot of walking, it might be a better option in that scenario. Now, if you have a fracture, you shouldn't be taking NSAIDs typically, because it can, like you mentioned, inhibit bone regrowth. But again, should be a discussion you have with your orthopedic doctor, most likely. That'd be helpful. That goes back to what some of the other options. And antidepressants that I mentioned can both help bone and muscular pain, which is a major complaint in HPP patients, and they don't have that same problem with renal dysfunction or gastric problems and whatnot. So that would be an alternative option to be used as more of a baseline treatment, rather than utilizing NSAIDs for your prophylactic or baseline treatment.
Okay. Great advice. Okay. There's another question. I think we have time for one more. That's interesting. And that's really understanding how to articulate the root cause of the pain to understand how to best treat it. So for example, the question is, how do we know or treat pain that could be caused by a common injury like tennis elbow versus something like calcium deposits in the elbow because of HPP? What doctor do you go to kind of get to that root cause? And is there one that you would recommend over the other to get to the best modality of pain treatment?
That's a really great question. I think that you're going to require more workup when you have a chronic disease process like HPP, meaning you might require an X-ray or an MRI to look at the pathology more clearly than if it was myself going in with a problem with the elbow. We could assume it's more of a tendonitis or whatnot rather than a calcium deposit, which may be present. So the physician or the provider, doesn't have to be a physician, but they need to be aware, that you have hypophosphatasia, and that should mitigate the discovery of what the root problem is. So you may have to do more testing for that reason, but also they should be aware of what the treatments are in that context. So sometimes a steroid injection into a calcium deposit can reduce that aspect, and it needs to be usually it needs to be under fluoroscopy, because you need to see exactly where you're injecting the medication. Whereas with tendonitis, if you get it right around the tendon, it typically is fine. So it's a more involved process and takes a little bit more oversight. So whether that be an orthopedic surgeon or an interventional pain physician, typically a good conversation and with understanding of what it means to have hypophosphatasia is important, because there's a lot of my colleagues at my own institution don't even know what hypophosphatasia really entails. I do, because I have a relationship with our endocrinologist, and that makes a big difference. But like Dr. Rush says, it takes a village when you're managing these, and clear communication is really important.
Yeah. Yeah, and with that's excellent advice. Thank you so much, Dr. Sobey. We really appreciate it. And again, we will contact you after the meeting to try to answer some of those additional questions, because there's some other really good ones in there, I think, that would help a lot of patients. So thank you. It's time to take a break. So you'll exit out of this presentation, and it's a great time to explore the platform, get to know your fellow attendees. Make sure you go over to that photo booth and take a photo so that we can see your smiling face, and to visit our lounges. And we'll be back in about 5 minutes at 10 after. Thanks so much.